All right, so we are live. What's going on, everybody? Welcome to the QOL Health and Performance Podcast. My name is Dr. Joseph Rayner, and I'm joined once again by Dr. Rashi Anand. And today's episode is basically part two of our chronic pain talk, right? And so last episode, we did a really good job of diving into the basics behind chronic pain, as well as the evaluative portions of, like what could potentially lead to it, how can you identify it, and kind of glossed over a bit of like what we can actually do to help address it. And so with this second part today, what I wanted to do was, or what we wanted to do was basically have a part two so that we can go over some more positive news as far as like, what are the things that we can actually do to help people with this? Because there are some interventions out there that we can utilize. And so, that's essentially what we wanted to do for this episode here. So how I want to start this off basically is, first and foremost, as far as how we want to be able to best help our patients who are dealing with this kind of condition. Essentially, priority number one, in my opinion, has to be patient-centered care, right? So Rashi, like in your mind, I know that's kind of a loaded question that's coming up right now, but in a nutshell, like what would you say is like patient-centered care to you?
Yeah, so patient-centered care to me, especially, obviously with all of our patients, this is crucial, but when we're speaking specifically of the chronic pain population, self-agency is critical.
Yep.
That's the piece of it, right? And you want to gauge at first the motivation level of these patients, right? Is this patient highly motivated to get back into doing what they want to? Or are they sort of in that ambiguous state where you may have to use strategies like we'll probably talk about in motivational interviewing, or are they in the lower end of that scale where they're really not motivated? But essentially what patient-centered care is instilling self-agency, whatever that may be, either demonstrating to the patient, hey, you can do this, right? So that they have this sense of kind of self-autonomy and can carry on their own care. So our patients have proprietary rights to their body, right? They choose their care. We don't tell them like, hey, you should do this because I'm telling you to do this, but they should feel like I'm doing this for myself, right? How is this related to my function? And that's what patient-centered care is. Essentially, you have the patient instilling that self-agency and that self-autonomy, self-efficacy in order to return to function.
Yep, exactly, 100%. And then to kind of piggyback off of that, as far as interventions go as well, I think it's really also important to discuss a topic that could have its own podcast episode, honestly, related to something we talked about recently, which is about like the social determinants of health, right? And so, not all patients are the same as far as like their backgrounds and what they are experiencing on a day-to-day basis, right?
Mm-hmm.
And so, we can have the best rapport with a patient, right? And we can have the best practice care plan in mind. But for example, if there is someone who does not have their basic needs of life in place,
Mm-hmm.
our ability to help them is going to be limited compared to someone who is not in that same situation, right? And so in some cases, depending on how bad that can be, sometimes as providers, just being able to provide resources to address those concerns can even be more crucial than just the simple like exercise, manual therapy, education pieces that we utilize on a day-to-day basis, right?
Mm-hmm.
And so I just wanted to throw that in there because I think that's something that is not talked about enough.
That's something I'm actually truly passionate about, is the discussion of and the implementation of the social determinants of health.
Mm-hmm.
I actually recently just wrote an article about setting foundations for the social determinants of health. So for those who don't know, social determinants of health are these basic foundational subsets and subcategories that improve the overall health and welfare of the population. So for example, health and health education, education and access to education, social and built environments, as well as economic stability. So these are the 5 social determinants of health. And it's the amalgamation of these 5 that really improves the welfare of the population. Now, if you're missing one, if you're missing two, right, now that's really going to deter you from day-to-day functioning.
Yep, exactly. And then also to piggyback off of that, like some things again that is not talked about enough as far as technological advancements in healthcare go, right? Because that also impacts social determinants of health as well, right? So for those who are technologically illiterate, which people are probably surprised as far as like the number of people in the US who still don't have access to good broadband internet, right? Those that live in like more rural areas, if we're talking about, physical therapy specifically, like our age population that more so needs musculoskeletal care compared to other age groups, right? Where, that technological literacy can really play or really impact their care as well, right? Where, for example, like the company that I work for, aside from what I'm doing with this, there are a number of times now where I've had, my older patients who, they have outcome measure forms to fill out and other forms of paperwork that the company that I'm working for has decided to keep strictly electronic, which they really struggle to be able to figure out kind of how to navigate that and how to fill in those answers accurately and whatnot, right?
And another kind of component of the technology is health literacy, right? Not only access to the technology, but then also access to health literacy. Are they actually able to comprehend the questions within the questionnaires themselves?
Yep, exactly. So, it gets complicated when you really dig into the weeds of all that, right? But again, like the important thing to note on a more positive spin is that I think providers nowadays have a much better understanding of this now than ever before, thankfully, right? So as these technological advances continue growing, as like Amazon purchases this big like primary care business, and now they might get into the primary care scene and whatnot, it's important for people to know that as providers, we are aware of these kinds of limitations and aware of these issues. And a lot of us are working hard to be able to figure out good solutions for this, right? So just wanted to throw that out there. That's important for people to know. Right?
Yeah, for sure. And it's going to be an ongoing collaborative process between interdisciplinary team members, but it's definitely a very interesting topic.
Yep, absolutely. All right. And so then the next topic to discuss as far as like things that we can do for you, and I would say more so specific to physical therapy, is being able to identify during an evaluation any potential red flags that maybe your primary care or other physicians have not yet had a chance to pick up on, right? And so one thing that's really important for patients to understand, and people in general, right, is that physical therapists are experts in conservative treatment for musculoskeletal conditions, okay? And on top of that, we spend many years studying the musculoskeletal system, but also we do have background in things like internal medicine, pharmacology, and things like that. Like we cannot have graduated from our schools without learning those kinds of things and being able to identify systemic conditions that may be contributing to your pain that other providers just have not had a chance to pick up on, or maybe they didn't think of it yet, right? And so that's important for people to know too. Now, keep in mind, as far as physical therapists picking up on red flags are concerned, those are rare instances. Your primary care providers, your specialist physicians, they are very well trained in what they do. They spend a lot of time in school. And so it is not very often that they miss those kinds of red flags, but it does happen, right?
And I think kind of going off of that, red flags, we can pick it up, but I think it's more of when we talk about yellow flags, especially for the cognitive affective individuals, it's picking up on yellow flags, which is becoming crucial to our care, crucial to our discipline.
I agree with that as well. Yep, exactly. Like, if someone who falls under the chronic pain spectrum or presents with like fear avoidant behavior, which is a very common yellow flag that I've seen, at least. That's important to address, right? Like, they have this perspective in their mind that they may hurt themselves or make their pain worse if they do XYZ movement that they want to do or need to do, right?
I agree. And actually, anecdotally, this was during my live patient exam. So It was in the residency. We have live patient exams, and it was a really kind of interesting case in that my primary role was to provide interventions based off of what I thought was a primary diagnosis.
Mhm.
Right. So whenever we think about chronic pain, we always have this tendency to think about, chronic spine, either neck or low back pain, which is not always going to be the case.
Right.
You can get chronic pain for extremities. So my patient was particularly shoulder. And her primary, at first, I thought was more movement coordination, more towards that kind of the instability realm. But it was actually cognitive affective tendencies, right? So day one evaluation, I might not be doing much instead of providing, pain neuroscience education, or really getting an understanding of what she thinks is the issue or what she thinks is the reason for the pain or the cause of her pain. And going off of, the intervention strategies, I think that's a pretty good segue is, in this case, if a patient is presenting and then they're using things like, my body's broken, or they really don't have as much self-efficacy, like, oh yeah, I can't do this. If I do this, I'm going to be in pain, that kinesiophobia.
Mhm.
What do you do in that case, right? Do you just ignore the fact and just go on and continue taking your tests and measures? Or is that a good opportunity to take a pause and open or send an invitation to open up this conversation? Because not every patient is going to be comfortable talking about pain.
Mhm.
So
Yeah.
I think that's the other important thing is using, have you ever heard of OARS before? OARS. So it's open-ended questions, affirmation, reflection, and summarization.
Yes.
So it's a very common, and I think it's a very easy way of delving into motivational interviewing is
Yes.
by using things like open-ended questions, right? So first you're sending that invitation like, hey, are we open to having this conversation? Then using open-ended questions. So kind of staying away from those I statements. I think you should do this. I think this is what's wrong with you.
Right.
Ask
Exactly.
them, give them the opportunity rather than blatantly asking yes or no questions.
Right.
Affirming, right? Affirming what they're feeling, because what they're feeling is very real.
Right. And then kind of also sometimes you also have to get creative on how you ask the questions in order to get them engaged too, because sometimes patients, like you said, are not too comfortable talking too much about their pain or like the different causes and whatnot. And so sometimes you have to kind of leave the floor open or even kind of catch them off guard with the way that you word your questioning, right? So like, for example, very common question that providers are going to ask you is on a scale of 0 to 10, how much pain are you in, right? And then, a patient may or may not respond to that. Most of them do, okay? And, you can choose to leave it at that, or you can try to dig in a little bit, right? So say someone gives a pain rating of an 8. And as a provider who is trying to dig a little deeper, a good follow-up question would be, how come you didn't pick like a 4 or 5?
Mm-hmm.
Like what thought kind of was going through your head when you were asked that question, right? And that will like stimulate their mind a little bit of like, like why didn't I? Oh, well, here are the reasons why, right?
Yeah.
And
Or
so
even,
without me having to ask,
yeah,
why are you having all this pain, like, and being very like interrogative,
exactly.
find another way to word it and get the
Even the other way around, if it's, an 8 out of 10, why isn't it a 10 out of 10?
Mhm.
It's like, oh yeah, I do have pain, but it's not always constant,
Mhm.
right? So they're already exploring the avenue of there's still hope of getting better
Yes,
because it's not
exactly.
constant.
A little positive spin too.
Exactly.
Mhm.
Exactly. And that's kind of the beauty, and that's where you have to be so creative is how can I turn this situation into optimism, and how can I show the patient, or how can the patient see for themselves that this, like, conservative management, it's worth trialing it out,
Mhm.
right? That there is the hope at the end of the tunnel, right?
Exactly.
It's trying it out, kind of encouraging and instilling that self-efficacy. And oftentimes you can do that through something called a graded exercise program.
Mhm.
So if someone is, let's say someone who does have fear avoidance and they're unwilling to participate in, let's say, walking, right, for X amount of miles, all right, like what if we start you off in a schedule? And every week you're incrementally increasing by, let's say, a couple minutes.
Mhm.
So at first, try, 2-minute warm up, 5 minute of fast paced walking, and a 2-minute of a brisk walk. Then the next week, why don't we turn that 5 minutes into 7? The week after, why don't we turn it into a 9, right? If 9 is too much, okay, let's go back to 8. And that's another really beautiful intervention strategy is activity pacing, but then graded exercise progression.
Mhm.
Is each week or each time, each session, you're adding on another component or another layer.
Right. And so, again, picking back off of that, because I really love that example of like that graded exposure to activity and just like gradually building up from where they had started. Right. And so then that tends to be the case with, most like musculoskeletal conditions, as well as even in just like in fitness, right? Like you don't want to go from point A to point B in just like 1 week. Like that's not very realistic, right? And that becomes especially more apparent in someone who is dealing with chronic pain because of the complications that come with that condition, right?
Mhm.
And then on top of that as well, I think it's also really important to note, like, going back to putting a positive spin on some of the things that we talked about in part 1, right? And so again, we're going to dive a little deeper into this a little more, but as far as like when we look at individual interventions and their ability to influence a person's pain, we know that in general across the board that it's pretty limited, right? That there are people who do get good outcomes and then there are those who don't, right? However, like let's say in the case of someone who is not going to be responsive symptom wise to like gradual exposure to activity or other kinds of interventions like that, but they are now able to walk 30 minutes with tolerable levels of pain, whereas before they were not, right? So their pain levels are still at that like 8 out of 10 at its worst, let's say if they're at nighttime, at sleep or whatever, but now they are physically able to do more. We have still improved their quality of life and their overall functioning because of that, right? So that's important to accomplish as well, right?
And then that's why we use those test retest, and that's why we use not only kind of subjective measures but objective measures too, right? Patient may report, yeah, I have 10 out of 10 pain, but hey, you walked 30 minutes. When was the last time you walked 30 minutes? Oh, it's been years.
Right.
Right. So now you're getting that 10 out of 10 pain at the 30 minutes, whereas before you were getting it at 5 minutes, right?
Mhm.
So, and that's another thing that you want to continue to reiterate is the functionality piece. And oftentimes moving away from the pain and the symptoms. Yeah, that's important, but how is that improving your function, right? So show the patients like you're able to do this now. All right, you still have that pain, but now you're able to do so much more
Yep.
with that pain coming on later in the activity.
Right. Exactly. It's acknowledging those small wins because they are important to recognize, especially with someone who is, living through a very negative experience. Any kind of positive that we can bring into their life, I think that's really important.
Mhm.
All right. So this next thing I want to talk about, which I think is very debatable in the healthcare world as far as like um, the chronic pain population goes, is related to imaging, right? And as far as, when should we do it? Should we really do it as often as we should be? X, Y, Z. I'll start off with this, right? So typically, if you are going to see a provider for a first time, whether it be primary care or whether it be, let's say like an orthodoc or whoever, right? Um, if there's unclear data from their evaluation with you for the first time related to your musculoskeletal pain, a lot of the times they will decide to do some form of imaging like an x-ray, right? To try to help them get a better answer as far as what's going on, right? That tends to be a very common thing that happens. However, it's important for people to know, first of all, with x-rays, unless you have like a bone fracture or a serious like systemic pathology that an x-ray is able to pick up on, usually x-rays are not very well indicated for use. And then the only other real reason that someone would x-ray you is if your insurance requires you to get an x-ray before you get more advanced imaging for something else, right? So that's number one, right? Is like those are important considerations. Now, going back into the advanced imaging I talked about, right? So a lot of times you get an x-ray X-ray doesn't really show much at all, or at least doesn't explain why you're having the pain that you're having. And then you go into advanced imaging like an MRI, right? And then the MRI, you see a likely some pathologies or abnormalities, right? Which, those abnormalities are actually very normal in a lot of cases, but the doc may look at that and be like, oh, you know what, this might be why you're having the pain that you're having, right? And the unfortunate thing, though, is that we are starting, I would say it's fair to say, we are starting to understand now that that approach is not the best approach for someone who's dealing with chronic musculoskeletal pain.
And then that's the other, and then we talked about the concepts of neurotag last time.
Yes.
Right. So especially someone who already has a pretty heightened nervous system, and all of a sudden now you're also showing them something that's wrong with their body through an MRI. And now they're bringing that to you in the clinic, like, look what they found. I have all these disc bulges in my spine, right? And then you show them the data. Yeah, it's like, yes, 60% of patients in your, or 60% of population has some form of disc bulge in your age. But how many of those are asymptomatic? Not many, right? Imaging has its place, right? But there are certain instances where that may actually impede progression, right? If someone, especially if a patient is so caught up in their imaging, like, this is what's wrong with me. I have, so many things are wrong in my back. This is irreparable, right? That's where it becomes a challenge of, as a clinician, right? How do you convince them, or how do you get to show them that you are not your image? You can take an X-ray, an imaging of my back, and find something. Am I symptomatic? No.
Right.
Does it mean anything? Probably not, right? Doesn't really mean much unless you do have those symptoms. But how is that correlated to the image? Is that what's shown in the image causing it, or is it something else? And a lot of the times for these patients, it's multifactorial. It's not always going to be the tissue that's shown in the image that's the issue, but what's happening outside of that. So those cognitive affective tendencies, the environmental factors, social factors, the biophysiological factors, the psychological factors.
Exactly. And so to kind of, shift into the next topic there, let's talk a little bit about like the psychological factors and how, at least us as physical therapists, we can help address that, right? So a very common like joke that a lot of therapists make is like, you can't spell physical therapy without therapy, right? And so, a lot of people that we see when they are, suffering through these like musculoskeletal pains and whatnot, and that's what it is. It is a form of suffering. It is a form of disability because they're in pain and likely not doing what they are wanting to do with their life, right? Or at least to the degree that they want to do it. There's going to be some psychological complications with that, or considerations with that, right? Now, it doesn't necessarily mean that they're going to have full-blown like diagnosable depression or anxiety or things like that, but that doesn't mean that they don't have like minor forms of that, right? That need to also be addressed. So like, when you are working with someone that you are identifying with like chronic pain, right? Like what kinds of things are you looking for when it comes again to those like psychological factors there?
Like ways to address it.
Yeah, exactly. Like best ways to address it.
Yeah. So I do want to put this out there that, our talk therapy buddies will always be there.
Yep.
So those psychologists, right? If it's someone, I mean, that's their scope of practice. That's for their specialization. They want years of training specifically for that. But I think it's also crucial to realize that as a physical therapist, we still can assist or at least facilitate that discussion in order to get them to the point of potentially seeing a psychologist, right? So some strategies that I will use, I've actually prescribed, there's a website called retrainpain.com. And it's a series of these short snippet 1-minute videos running through, what is pain, just for individuals to get a little bit of a better understanding of what it is they may be feeling in layman's terms, right? Other strategies I employ are at least based off of Adrian Lau and Professor Mosley's concepts of pain neuroscience education. So there are these two pioneers when it comes to pain neuroscience education.
Definitely.
And employing these metaphors to help better conceptualize what pain is. It's a complex process that involves multi-systems, and stating it in a way for someone with basic level education to understand is challenging. So they came up with certain metaphors of, the alarm. I don't know if you've heard of like the alarm system metaphor, the lion. Have you heard the lion one before?
Yes.
Yeah, and it just they have all these articles published, and it's really worthwhile, especially if you're a healthcare provider, using these metaphors to help better explicate what pain is. And other things that I will utilize, especially for this group of patients, is getting them away from pain, or at least using the term pain,
Right.
and implementing more function to it. And that's what we do as physical therapists, right? So I like to use, if you have like 0 to 10 scale, right, and they're at a 5, like it's all right if it goes up to a 7, if it's able to come back to a 5. I don't want you to focus on your pain, focus on the movement that you're doing. And one of my mentors, actually, he does this a lot with his chronic pain population, and I've started to implement it a little bit into my own patient care population, is using multiple systems of the body in order to kind of recalibrate the system. So you have the musculoskeletal system, right? That's not the only proponent of movement. You also have the cognitive, right? Then you also have the somatosensory. Then you also have the cardiovascular. So if we're focusing on movement, why are we only focusing on the musculoskeletal? We can add a cognitive piece to it, right? So have them count backwards from 7 when you're doing an activity. Add like an unstable surface or a foam pad or whatever underneath to add a little bit more of a balance. Have them close their eyes to add a little bit more proprioceptive and vestibular. And that's something that I've actually seen be really, really helpful, especially for this population.
Absolutely. And again, just I think I really want to hone this first part that you said, like the psychologist aspect of things, right? Like referring to our friends, the therapists, right? I think that is super, super important and underutilized, even in our profession. I feel like, just that, like you said, it's within their scope. They're the ones that are most trained to be able to take care of those kinds of things. But at the same time, in the instances, and this happens to me every once in a while, where if you identify those kinds of mental health issues and you think it's in the patient's best interest to be referred to a psychologist, there are times where they say no, right? Like, oh, I've done that before, actually made it worse, or I don't think it works. I don't think it's going to work for me. And again, this circles back to patient-centered care, where
meet them where they are too.
Where they are, exactly. Yeah, like if they are not willing to do that, don't show frustration. Don't get mad at them because they are not listening to you, even though you know that's in their best interest, or you think you know that's in their best interest. We don't know that for sure, but you know what I mean. Like you need to make sure that, again, like you said, we all need to meet each other in the middle, where it's a team effort, right? And at least open the door and say, I'm not an expert in this. However, if you ever want to talk about these things, we can talk about them, right? At the bare minimum, at least like leave that door open for them, right?
Exactly. So sending, again, that's patient-centered care. It's now up to them and up to their control to decide their path, rather than you telling them what's right for them.
Yep, exactly. All right. So the last thing I wanted to talk about, related to chronic pain management, it is about manual therapy. Okay. And so a number of colleagues of mine, and maybe other people on the internet I've had conversations with, think that I'm anti-manual therapy when it comes to chronic pain. Okay. And honestly, my answer to that is not really. It just depends on the situation, right? And so, as long as we are acknowledging with manual therapy that we are likely going to improve pain in the short term and improve range of motion for the short term, and that's what the intent of that intervention is, so that maybe they can do more with their exercises later in the session and whatnot, I am all for that. I do that in my practice, okay? However, there is a large stigma and belief that manual therapy does more than that. And I just don't think the research supports that kind of mindset or thinking.
And I think, personally, when it comes to manual therapy can have neurophysiological effects. Just that sense of someone providing, gentle touch or
Right.
comforting touch, right, can have that neurophysiologic impact.
Mhm.
Yes, short-term pain relief, range of motion improvements, you can see that. And I think you nailed it. The important part is, first of all, your reasoning for manual therapy, right? I hope you're not doing manual therapy just to kill time and get more units. That should never be the reason for why you're doing manual therapy.
Exactly.
But the even more important aspect of it is, and this is something that I've been honed upon here, is following up manual therapy with something that's functional and something the patient can replicate at home. So, okay, if you're doing a joint mobilization, all right, cool, I'll see you next session. Where's that self-efficacy? How can a patient replicate that at home? They can't,
Right.
unless you have an intervention or strategy. So I think manual therapy for chronic pain population, I typically tend to, maybe initially I might do some, especially just to build rapport with the patient, right? And they see this sense of comfort, and I'm someone that they can really, tell whatever they want, or I'm open and you can communicate whatever you want with me. So initially I may use a little bit of manual technique, but eventually, yeah, it's moving to the functional piece, which is the end game.
Right. And I think also it's important to keep in mind that like utilizing the manual therapy can be beneficial, again, in creative ways. So like you said, it's a good way for the patient and the therapist to build rapport together, which that's going to influence outcomes, right?
Yep.
Another thing also is taking that time to educate the patient, maybe not necessarily on the manual therapy interventions after the first time you do it, but on other things as well, right? Like, so, instead of sitting down together and talking, you can be performing some form of manual therapy while you talk, right? And then, like you said, move on to something functional, move on to something that is going to provide some kind of muscular physiological adaptation over time, right?
And that's important too. It's like when you're doing a pain neuroscience education, it's not necessarily about sitting that patient down and talking to them face to face for 30 minutes. You can implement snippets of P&E, pain neuroscience education, throughout your session, whether you're doing manual therapy, if they're doing a therapeutic exercise, if they're doing diaphragmatic breathing. So P&E snippets can be implemented throughout care, and it doesn't have to be a one-day thing. So it's not like, oh, I'm going to do all my P&E during my evaluation. No, you can incorporate it, the follow-ups, you can incorporate it during discharge, whenever. It's not sitting the patient down, having this conversation for 30 minutes. It's something that can be utilized over and over again over follow-ups. And you also don't want to overwhelm the patient first day. So you're probably not going to read out of a book, right?
That's where those snippets come in.
Yeah. Yep. So it's like snippets, and then there might be certain individuals where you might need a little bit more than a snippet. And that really, as a provider, is something for you to be able to identify early on is, will this patient benefit from a pain neuroscience education? 2, if they will, how much, right? Do they just need a snippet of it, or do they actually need a little bit more? 3, if they do, who can I refer them out to?
Right. Exactly. 100%. Awesome. Well, Rashi, I think we nailed it again. That was awesome. That was awesome.
Thanks for having me again.
Of course, it was a pleasure.
Yeah, it's definitely a topic that I'm super passionate about, and especially how it relates to the social determinants of health, and where I think that's becoming a little bit more prevalent in our society, only because we're able to identify it a little bit more than we have been previously. It's always been there.
Definitely. All right, guys. Well, again, if you guys ever have any questions, you are more than welcome to reach out to either myself or Rashi on our social media pages, or you can comment on the YouTube video as well. I'll be sure to leave those links and information in the description there. And again, Rashi, thank you so much for your time. Everybody else, I'm looking forward to seeing you guys on the next podcast. Thank you.
All right. Thank you. Have a good one.